Good afternoon, my name is Griffin Russell. I'm honored to be presenting to you today. Before I get started on my presentation, I'd just like to acknowledge the incredible work that's been presented over the last 2 days. It's very inspiring. The project that I'm presenting today is the development of an overdose prevention and management group in the community of NANAIMO. This project occurred within the context of a work-based practicum placement within my position as the harm reduction coordinator with Island Health. The position itself is situated within the communicable disease program as part of the public health portfolio. It works in conjunction with the Provincial Harm Reduction Strategies and Services Committee, which is with the BC Centre for Disease Control. It's one of 4 such positions right now in BC, and it's responsible for supporting harm reduction supply distribution across the island, as well as education opportunities, training, and harm reduction services just in general. The inspiration for this project came from the unfortunate findings from the BC Coroner's Service, which reflected a developing public health crisis related to fentanyl-detected deaths. My apologies for not making this clear here, but these are provincial statistics. So as you can see, in 2012, there was 12 fentanyl-detected deaths in the province, followed by 50 in 2013, and then 88 in 2014. Specifically in NANAIMO, there were 8 in 2013, which was the most in the province, and 10 in 2014, which was second most in the province. And at current state, the fentanyl-detected deaths in NANAIMO reflect over 50% of the overall overdose deaths in the community, so it's certainly significant. Among these cases, 16 of the 18 showed signs of extensive drug use history, and that will become important later in the presentation. I'll come back to that. In January of 2015, the BC Centre for Disease Control conducted a fentanyl urine drug screen survey. And as you can see in NANAIMO here, although it was a small sample of only 15 participants, 10 of those 15 did show signs of fentanyl in their urine samples, which although is a small sample, again, it does support the risk that we knew is there, and supported the development of this group in general. So the purpose of the project was to bring together the key stakeholders within the community to consolidate the different data streams that were available and look at the different resources that could support us in addressing this concern. So some of the activities would include identifying and recruiting these data streams, including fatal and non-fatal overdose cases, communicating drug alerts, expanding availability of the take-home naloxone program, and just to kind of refresh, naloxone is an opioid antagonist. It's integral in terms of first line of defense for opioid overdoses, including fentanyl. We also want to increase the use of 911 and emergency services in the event of an overdose, and then look at contributions to the BC College of Physicians and Surgeons in regards to opioid prescribing practices. Within the literature, there wasn't, I did a literature review, there wasn't an extensive body of literature there, but what was there really helped to frame the work that was going to be done in the group. And so Project Lazarus, which was in North Carolina, was the most extensive and comprehensive example of this, but also Chicago and Pittsburgh had good examples as well. Fortunately for us, though, within the province, we have incredible work being done at the BC Centre for Disease Control. They are the founders and the holders of the Harm Reduction Strategies and Services Committee, which has representatives from throughout the province, including the Drug Overdose Alert Partnership. Among the findings, the most relevant components of a overdose prevention program would be the coordinated sharing of epidemiological data, providing and distributing timely and targeted communication and alerts within our communities, enhancing overdose prevention training and access to take-home naloxone, as well as increasing the use of emergency services. Currently, it's roughly around 30 to 50% of overdoses actually call 911. So some of the data sources we're utilizing right now, the most significant is coming from the BC Centre for Disease Control and this Drug Overdose Alert Partnership, or DOPE, which is a little ironic in its naming. One challenge I'll note about that is some of the key streams of data are Victoria and Vancouver specific, which when you think about localized problems such as the one in NANAIMO, it doesn't help us to kind of narrow in and target our strategies. So we're also looking at the Discharge Abstract Database, or DAD, from the Emergency Department in NANAIMO. The only problem with that is that there's a time lag because it has to be manually entered. So we're really trying to strategize how that will influence our work moving forward. We'll have ongoing case reports from the BC Coroner Services and anecdotal reports from peers, including through AIDS Vancouver Island and NANAIMO Resource Services for Families. In developing the meeting, what I tried to do was look at what the relevant data sources were and go directly to them and request those for the purposes of our meeting, so that it was people were on the same page in terms of what the concerns were, what the realities were, and how we could start to target our work together. That also included gathering current drug alert messaging tools and resources, and again, that's right now housed through the BCCDC. And then targeted invitations for attendance and ongoing participation. This is our working group as it stands right now. So we have our medical health officer from Central Island, who is also my practicum supervisor. But we have the chief pathologist, the manager of the emergency department, director of integrated health. But we also have representation from key services within our community, including the RCMP, fire department, ambulance services, and then as well the CDC and BC Coroner Services. I really just wanted to touch on this because it was a source of pride for me. Moving from direct practice and doing counseling and then into this more coordinating role, I described this meeting as the most important meeting of my life. And so I really tried to set it up where it flowed, it had the relevant data and information, and it was organized in a fashion that I wasn't wasting anyone's time. So it went smooth. It wrapped up with about 3 minutes to go, and everyone was in, out, and with a commitment to continue on. It also led to a subcommittee, and that was around developing more localized alerts. In this communication subgroup, what we did was look at the communication tools and resources that we had with the consideration of, when I mentioned the 16 of the 18 showed signs of extensive drug use history, these weren't clusters of overdoses. These were spanned out over the course of 2 years. It was 1 per month, roughly. And so with the extensive drug use history in terms of people's backgrounds, you can't use scare tactics. You can't just try and beat people away from this. It's something that they might even be seeking out, and we've heard reports of that. And so we needed to tailor our communication messages to include more than just scary messaging. We did review the posters and information from Know Your Source and Be Drug Smart, but again, they had images of people on a gurney with a toe tag. They didn't provide any kind of overdose awareness or education, and so we really wanted to look at that and how do we make this more relevant for our purposes. This would be an example. We put it on orange because we wanted it to pop. The most up-to-date version would be date stamped so that people would know the history of it and that it's ongoing and that we need to continue to respond to this. But we also tried to put some prevention messaging in there as well as some signs of overdose. This was a two-sided business card. We thought it would be effective for outreach distribution among bicycle police and among our outreach community services. We had a follow-up meeting. It was really just to build off of that, bring back the work that we've already done, bring forward any kind of emerging data, and then look at future actions. These future actions would include increasing harm reduction supply distribution. Those are key in terms of contact with people and increasing awareness around this problem. But also expanding the take-home naloxone program, again, as that first line of defense. And then something that's, I think, really important is the RCMP have offered to come and participate in naloxone training to enhance the trust and safety among people in our community so they know they're not going to be punished. So some of the strengths and weaknesses, I know it's time, but I'm going to take some of Megan's time, if that's cool. I have the microphone, so I don't know what you're going to do about it. Some of the strengths are addressing a current crisis. People are dying. There's nothing more important than that to me, so we need to protect them. And bringing together a multi-sectoral participation group is also key. You can't do this alone. It can't be just health. It can't be just enforcement. We all need to work collaboratively. Some of the weaknesses, I would say, again, people are dying, and so how quickly can we get our stuff together and get this out there and do it in a coordinated fashion that really enhances people's protection. I'd like to just thank, first and foremost, all of the youth, adults, and parents that have given me direct education over the past 15 years. Without their wisdom and knowledge, I wouldn't be here, so that's paramount. Some of my workplace mentors, Todd Hasbeck, Chris Goebel, Dr. Stephanie McEwen, my big brother Travis. Betty Taylor, thank you so much for making this happen. This was not an easy practicum to arrange, so I sincerely appreciate that. Victoria as well, Dr. Worthington. And then also Dr. Hasselbeck. But to my family that's watching, I love you.
Thank you, Griffin. I gave you back 1 of the 2 minutes. I was getting ready to come up. It's like, okay, he said his 1 minute. I'm going up there
Thanks,
now.
Megan.
So questions?
Great job, Griffin. Thank you so much. Just as an FYI, I was just going to let you know, and as well everyone in the room, that in the last 2 weeks, the scope of practice for registered nurses in BC has been changed to allow for the dispensation of naloxone in the absence of a physician's order. So to the best of my knowledge, we're the first in Canada. Took about a year to go through all the sort of hoops. So as the antidote to opioids, naloxone still in Canada is listed as a Schedule 4 drug, meaning that it has to be prescribed, which is ridiculous, but in any event, that's my little soapbox about that. But it is by no means are registered nurses only capable of dispensing naloxone, but it's just another way to increase access in communities. So thanks for your presentation.
Thank you for bringing that up. That's automatically led to the implementation of take-home naloxone in Port Alberni already in 2 different locations, as well as 2 locations in Parksville. I agree with you in terms of the ridiculousness of how it's been set up to date, but certainly that's going to be incredibly beneficial.
Yeah, I just want to say that was a terrific presentation, first also thanks. I really like specifically the communications materials that you guys developed to hand out to peers in NANAIMO, and I may have missed this, so I was wondering, in the information, is there a way that, and I'm ignorant to this, so excuse me, but that people who are using drugs can tell if the drugs that they're using are mixed with fentanyl?
On a more immediate basis, not that we're aware of. We're looking into it, and certainly we're trying to pursue every option in that regard. But as we know right now, no. But if anyone in here is aware of anything different, I'd love to hear about it. Great question.
Thank you, Griffin, and thank you for the amazing work that you do. I wanted to ask, how do you involve the target group in developing these plans?
Yeah, thank you. So with all of our communication tools, they've all been tested within our service agencies in the community to get the feedback in terms of the relevancy, in terms of the literacy and the language that we've used. And then we're going to look at developing some peer groups within NANAIMO, specifically to support one another in terms of the peer-to-peer, but then also in terms of guiding our work moving forward.
I'm over here. Hi. I seem to be just constantly thinking back home in Alberta. I know in one of our southern First Nations communities, there's a huge problem. There was a big dump of oxycodone that had fentanyl in it, and it became a really, really, really big issue. I'm wondering, how does work with Island Health, is there any work with Aboriginal people or Indigenous people on the islands? Does this work extend to those communities, or do they have a different avenue to access these kinds of services here on the island?
They do. It's somewhat community dependent, but part of the Harm Reduction Strategies and Services Committee does include the First Nations Health Authority and representation from there. So it's something obviously that we're always aware of and trying to keep in the front of our mind and always working towards.
Thank you, Griffin. And just before, or maybe as Griffin leaves the stage, your new baby is Rory, did I get that right?
No, Romy.
Romy. So we've had numerous, well, at least a few babies this year.